All right. Well, I clicked it. Yay. All right. Good evening, everybody. I am so excited tonight to have Dr. Chapa on to discuss PPROM. It is PPROM Awareness Month. And welcome to our live discussion on this. If you don't know me, I'm Liz O'Donnell. I am Aaliyah's mom and the co-director of Awareness for Push Pregnancy, where our mission is to end preventable stillbirth and just empower pregnant individuals with all the info they need. And that is why I am just so happy to have Dr. Chapa here with us this evening. He is a board certified OBGYN and serves as, oh, my dog is making a lot of noise, as a clinical assistant professor at Texas A&M College. And he's a nationally and internationally recognized speaker and published author in the field of obstetrics and gynecology. So thank you so much, Dr. Chapa, for being here this evening.
Yeah, Liz, and listen, this is super important. We take for granted that when we get a positive pregnancy test, somebody who's been trying to conceive, and we get that little stick with a little line, and we're like, all right, everything's going to be great. And then life happens, and we have to be prepared for that. We have to be prepared for that from a medical standpoint, whether we're a physician, nurse practitioner, midwife, PA, it doesn't matter. We all have to be on the same language, have the same thought process of how to expect it. And PPROM is one of those things. So thankfully, guys, we're going to go over some really impactful stuff, be very honest, have good discussions. None of these are my ideas. I want to be very honest. My ideas follow what the evidence tells me. So we pride ourselves on 3 words, which is evidence-based medicine, so that we can take the best care we can for our patients to help try to protect these little babies, because it's heartbreaking when we're on the right track and then the storm comes and it throws pregnancy for a loop. So thank you, Liz, for doing this. It is PPROM Awareness Month. And so let's get to it.
Yeah, let's get to it. And I also just want to kind of say as a disclaimer, if you have any questions about your pregnancy right now, and if you're feeling like, oh my gosh, I need to talk to someone immediately, please contact your medical provider. This is a discussion where, we're really just educating. And, I honestly didn't know that PPROM was a thing up until I entered this community as a lost mom. And so, if you are pregnant, this is just a way to help empower you to learn more. And if PPROM is a condition that you've had in the past, to kind of just learn more on future pregnancies. So with that, let's just jump right in. What does PPROM stand for?
Excellent. Man, guys, we have so much to talk about, from management to prevention and overall awareness. So let's take away some of the P's and put the regular P, which is prom, like the high school dance we all went to, if you went to your prom. So prom, actually, look how medicine moves, because things are evolving. When I trained, PROM stood for premature rupture of membranes. Okay. However, recently, within the last 6-7 years, while the concept is the same, the words have changed, because the term premature threw people off. All right, Liz. So, oh man, I'm so sorry. You're 39 weeks, which is full term. You have premature rupture. Well, how can you have premature if you're 39 weeks? But premature was meant to imply premature before labor, before contractions. So that P has now changed to be much more clear. It is now pre-labor rupture of membranes. The easy way to talk about it: if your bag water breaks, contractions aren't happening, that's PROM, pre-labor rupture of membranes. When it happens under 37 weeks, 37 is the start of term. Under 37, any baby that comes under 37, but over 20 weeks, the middle part of the pregnancy, that is called preterm, pre-labor rupture of membranes. All right. So that's the 2 P's. PPROM is preterm, pre-labor of membranes. And what the management of that completely depends, Liz, on one thing, how far along that baby is in the pregnancy. So we'll talk about that as we go.
Yeah. Okay. So how are you diagnosed with this? I know you said, your water breaks. If someone is experiencing this, how do you know?
Yeah.
what do we do?
Okay.
Yeah.
So it's interesting, even the words that we use, right? Like my water broke. Well, water doesn't break. Isn't
Yeah.
that weird, right? Things that we say, my water broke. Actually, what we mean to say is my bag of water broke, but we
Okay.
all get it. It's
Remember that.
universal, worldwide. My water broke. And
Yeah.
patients come in all the time. Well, water can't break, but I understand what you're saying.
Yeah.
So in general, the classic form of PRO or PPROM is an uncontrolled loss of fluid, guys. Remember this. Uncontrolled loss of fluid from the vagina, and you do not suspect it's urine. Now, to be honest, we're going to have open discussions. As you get close to term, that baby moves, you sit up quickly, the baby presses against the bladder. It is possible to have leakage of urine. And with a pregnant tummy, it's really hard to figure out, is that urine or not? The simple advice is, if you have loss of large volume of fluid and you don't suspect it's urine, please go get checked. Time is super important here to make the right diagnosis. So you asked, Liz, how do we diagnose it? Very easy. Two things: history and physical exam.
Okay. Yeah. And that's one thing, with PUSH, when we are trying to educate people on having an empowered pregnancy. I know for me, my story is very different, but I wanted to wait. I didn't want to bother people. I didn't want to make a call. I didn't want to do anything because I was a first-time mom, my first pregnancy, and maybe babies, just don't move as much towards the end or something like that. I feel like a lot of times, pregnant people feel like, oh, I don't want to bother anyone. Maybe if I wait an hour, it will be fine. But you are saying, don't wait. You've got to go.
No, listen, that's what we're there for. And patients come in all the time, very apologetic, but apologize for what? What? Remember, we work for you. So whether you go see a midwife and a nurse practitioner, us as a physician, if there's any question, get checked. Now, there's also that fine line, right? So if you know, and by your own check, wait, I got up, that definitely felt like pee. You can take a look at it, and I think that's definitely urine. It's okay. So you don't have to come in for every, small thing. That's where your own judgment comes in. But you open the door with allowance, the permission to say that's our job. So that's what we're there for. And the last thing that somebody wants to do is read a abnormal symptom as a normal one, and we're behind the ball. So I encourage anybody, if you got a question, it's as easy as either call the physician line or you're off the clinic line, because everybody has one, and or go for evaluation. The diagnosis, Liz, I think we can talk about it a little bit more because it is pretty straightforward. And it's gotten much better because while physical exam is still the main way to go, which we'll talk about if you desire in a moment, now we have something called biomarkers that increase our detection ability. And so physical exam and the use of vaginal biomarkers is how this diagnosis is confirmed or ruled out. Okay.
And so I know one of the questions we had gotten earlier was about prior conditions. And do any prior conditions lead to the likelihood of this occurring? So, do people need to be aware if they have X, you might be more susceptible to this happening?
Yes. Answer is absolutely. So let's cover some of those. So first, the cause of PPROM. So let's focus on the early, under 37. That's our focus here, right? Not the PROM, the term, which still is worrisome, but significantly drops the risk a little bit because at least the baby is older. The conundrums, the dilemmas come when it's very early, defined as under 26 weeks. And we can talk about it. That is heartbreaking. And to tell you how real this is, guys, 2 days ago, this happened to us in our practice at 23 weeks. Heartbreaking. Yeah. So these are real things that nobody wants to talk about, right? It's just everything's going to be fine. But this is why we're here. This empowerment of education, that there's hard things out there and you want to drive that boat. You want it to be smooth sailing until you pass that 26, 27 week mark where the baby, still very early, has a dramatically better chance of survival outside of the womb than under 26 weeks.
Right.
So the short of it is, what conditions can lead to this? If you have untreated infections in the vagina, there's evidence. Of course, we're talking about some things that are passed by intercourse, gonorrhea, chlamydia. Those can cause ascending infection into the uterus and cause inflammation, make the bag less strong, and therefore you get rupture. So you got to take care of yourself, know your partner, and get checked.
And is that's if you currently have that STI?
Yes, not
Or
past history.
okay,
That's
okay, just
correct.
wanna make sure. Yeah.
Yes, that's good. Absolutely.
Yeah.
Then there's things that we can modify, like the timing of pregnancy. So we know for over a decade that the stopping of one pregnancy and the starting of the other, that's called the inter-pregnancy interval. I'm done, I've delivered, and I'm pregnant again, of less than 18 months, according to the American College of OBGYN, Society of Maternal Fetal Medicine, World Health Organization. We can go down the list.
Yep.
We know that getting pregnant too quickly is probably not good. Okay, because there's nutritional deficiencies in the body, there's physical stresses, the body's ability to make a person.
Yeah. A lot of work.
It's a lot of work, right? So the shortest interval of 6 months, high risk, not just for PPROM, but of preterm labor, hypertension in pregnancy, diabetes. It drops 12, drops a bit at 18, but everything from end of one to start to the other of 18 months, a year and a half. Try to avoid that pregnancy for a year and a half. Plus, your newborn needs that attention, because that is one of the modifiable risk factors to try to reduce the chance of PPRM. One more factor, Elizabeth, before we move on, because there's so much to cover. So infections, timing of pregnancy, staying healthy, right? So if you're overweight, obesity has a link to preterm birth. So all of these factors go into play. And the other thing is, as you clear the first trimester, entering about 18 weeks, there is a test called an ultrasound that can be very predictive of preterm labor and ruptured membranes. And that's the size, the length of the tube that exits the uterus, the cervix.
Okay.
So a short cervical length, which is part of every 18 to 22 week ultrasound, is pretty standard in obstetrics. And measuring the cervix is so that we can get ahead of a potential problem. That's how we arm ourselves with prevention before it becomes a treatment issue.
Now, in that, with the ultrasound, would a doctor say, oh, this is what we're noticing and you could be more at risk for that? Or is that just kind of kept kept hidden as to not to scare? In this community, we are sometimes told, in all honesty, that we scare people by being honest and telling the truth about things to look out for. So is that something that a patient would find out, or?
Now, this is interesting because, Liz, I trained not that long ago. I'm not old, okay? But when I trained, there was medicine that was very paternalistic, which, Liz, was what you said. I'm going to tell you what you need to know, although I know more, and I'll hold what I need, and I'll tell you when you need to know it. Those days are gone. So, be very clear. If we see a short cervix, that is reportable. I mean, that is standard obstetrical practice by National Society guidelines. And the size, the length of that little cervix, and we're talking about, guys, it's not very large. We're talking about 2.5 centimeters at the minimum. Sometimes it's 3, sometimes 3. We're talking about 2. That's all, 2.5 centimeters. But less than that raises the risk of things like preterm labor and preterm pre-labor rupture of membranes. So, and that's usually done vaginal. Okay, it can be done transabdominal, but the best way to measure the cervix is by placing the camera inside the vagina and then measuring that length of the cervix to see its true dimensions. So staying healthy, getting infections treated, proper spacing of pregnancies, controlling things like weight, because BMI is linked to adverse issues, and then cervical length. In a nutshell, we're trying to do this to respect everybody's time and answer to the questions. Those are the big things that you need to keep on top of mind. So when you go in for that 20-week ultrasound, and they go, everything's great. You go, I'm sorry, what was my cervical length? And they're going to go, oh, no, okay. It's actually normal. Okay. But you got to check that box, and you have the right as a patient to ask questions about you.
Yeah. And that's exactly what we want our followers to do, is to ask questions like that, because I do think it kind of throws doctors off sometimes, but it kind of also lets people know, like, no, I am educated. I do know about this stuff. So I am so happy you said that. One thing that popped into my mind when we were talking about spacing out the pregnancies, what role, if any, does miscarriage play in that?
Okay, a different process. So let's cover miscarriage very quickly. So most miscarriages happen in the first trimester, which is up to the 14th week. Okay, most of those are, remember, miscarriages are very complicated, but the thing that should take the stress off of the patient is that we don't have the power to control that, or nobody would miscarry, right? We'd be on top of that. But there's some things in medicine we have release control, knowing that's how nature works.
Yeah.
Okay? So that's within the first trimester. Now, if there is a loss So to be clear, because it gets a little gray here, if there's a loss, let's say 18 weeks, okay?
Yeah.
Any pregnancy that is under 20 weeks is still considered a miscarriage. But the causes of that are very different in the first trimester. First trimester, usually genetic. Second trimester can be what's called an incompetent cervix, which Liz can present with rupture of the bag of water.
Okay.
So an incompetent cervix, if you think of a wet paper towel as the pelvic floor and the cervix, an apple and an is the uterus. As that uterus grows, the paper towel simply gives way.
Yeah.
That is a weak cervix. And that happens between that 16 to 18 week time. And patients come in and like, I know I can't break my bag of water because I'm like 16 weeks. So I just wanted to get checked. That's a flag for us.
Okay.
Hopefully it's urine. Hopefully it's nothing. Vaginal discharge, because there's a lot of other differentials that it could be.
Yeah.
But if it is, that is still a miscarriage, but by different mechanisms. And the way we would treat that in the future is by placing a stitch around the cervix after the first trimester called a cerclage. That's French meaning to encircle. Yeah, a cerclage. So it's a little bit different picture because here we're focusing on 20 weeks and above.
Okay, so if a loss occurred earlier and you do get pregnant again within that 18 months, it does not necessarily mean that you have an elevated risk.
Very good. That's good. Yes. No, there does not seem to be a risk from, right. So once you miscarry, the time, the interpregnancy interval here, this is, we're talking about preterm labor and PPROM. If somebody miscarries, and we had a miscarriage in our first pregnancy, we're like, we want to fight for this child. There's no evidence that waiting 1 year is any better than missing a period because you automatically got pregnant.
Yep. Okay. That's
so because that stress of the body is very different, right? So the answer of when should somebody who has a miscarriage get pregnant? The answer is when they are emotionally, mentally, and physically ready.
Yeah, absolutely.
And that may be a year, right? Or it may be a month, but the patient decides that.
Okay. And that won't. Perfect. All right. I want to make sure we get to some of these questions. And if anyone has questions too while you're watching, feel free to put them in the chat. We'll do our best to answer them. And if we can't answer them right now, we'll try to get you an answer later for sure. So somebody asked about the typical hospital stay or, time frame and I guess time frame for delivery once you have been admitted with PPROM.
Good. So it all depends. So when we're talking about PPROM under 37, look at the difference. If it's PPROM just at 37, it's like, hey, you're ready to go. We can wait for about 24 hours, see if labor starts, or we can automatically start you on IV Pitocin, the synthetic hormone to get the contractions going, and that's out. However, the management of inpatient hospitalization is based on gestational age. So based on national guidelines, if a patient has, because look at that spread, Liz, we're talking 20 weeks to 37.
Yeah.
That's a lot. And there's different boxes. There's pre-viable, meaning the baby just cannot survive outside the womb. That's less than 22 weeks.
Yep.
There's no lung development.
Yeah.
Then there's 23 to 26, which is called around viability. That's called peri-viability.
Okay.
So baby can survive, but it's going to be rough.
Yeah.
Let's be honest. It's going to be very rough. Then there is extreme early preterm birth, which is really from about 26 weeks to 28. Then there's early 28 to 32, late preterm, which is anywhere from 32 or 34 weeks to 37.
Okay.
The answer is if you're more than 34 weeks, while you can choose to wait if you want to, the risk of infection is higher. So national guidelines say it's best to try to induce labor, even though you're early, at 34 weeks and above. Under 34 weeks, inpatient hospitalization is recommended for 3 reasons. Okay. Now, not outpatient, inpatient. There is some data, and some countries outside of the US do it as an outpatient, but it's a different infrastructure.
Okay.
The 3 reasons why you want to be in the hospital is because labor can happen very quickly.
Mm-hmm.
Sometimes when your bag of water is ruptured, the placenta can also tear away from the wall. That's called an abruption.
Yeah.
And you want to be in-house for should things, these are low risks, but they are risks. You want to be in-house should that happen. And third, you want to monitor for infection. And I know we can talk about how that's done.
We'll talk about question that we had. Yeah.
So the short answer is yes. We're talking about a prolonged hospitalization. As long as the baby and the mom don't have an immediate need for delivery. And that would be mom is unstable, baby's not looking good on the monitor, or there's fever. Sepsis is horrible. It's horrible for the child and it's horrible for the mother. Sepsis we can lose both of our passengers on that boat.
Yeah.
So you really want to stay in house. I know it's terrible. It's not a prison, and of course, patients can choose what they would like to do. But the recommendation for patient safety is yes, if you have a true diagnosis of PPROM, we need you in house. We'll give you antibiotics. That's called latency to try to control infection. Steroids to help the baby's lungs. We give you a medication called magnesium to protect the baby's brain. That's until 32 weeks. So there's active interventions to try to watch that child, including daily non-stress tests. You familiar with that, right? So you put it on the monitor. That tracing, the baby is also a vital sign. Okay, I don't want to reduce it to that, but the baby talks to us through the monitors.
Of course.
So the short answer is it's extremely high risk to have a PPROM, and it's called high risk for a reason, which means you really should be under medical observation.
Yeah. And so now with that, let's kind of talk about the possibility of infections, monitoring for infections. That was another question that we had. What does that look like when you're in the hospital?
Right. Infections can present three ways. The typical is what happens when you have some kind of infection. Your temperature goes up. So by tradition, a temperature elevation of 100.4 that's repeated is a flag. That's something we would raise and go, unless you were under the covers with a heating pad, that's indication that we need to be out.
Yep.
So that's number one, temperature. Number two is increased uterine discomfort. That's called uterine tenderness, because the sac that's around the child is very prone to that inflammation and bacterial colonization. So you get uterine tenderness. And then the third is the discharge. The vaginal fluid that's coming out has a bad odor. It's infected.
Yeah.
So uterine tenderness, fever, malodor, we have to separate you two. And that's where it gets tricky at 25, 26 weeks. But I'm telling you, one of the biggest risks with extreme PPROM, extreme being 23, 24 weeks, is maternal sepsis. And guys, let's talk honest. I don't want to scare anybody, but maternal sepsis can be deadly.
Yeah.
So we got to act fast. We have to act fast. And those are not decisions, guys. Listen to me. These are not decisions we take easily. Like, well, let's just induce her. Let's just section her. That's not how it works. That's not how we work. We try to, what is the best chance for both of these people to survive without long-term morbidity? That's called consequences. Morbidity consequences.
Okay. Yeah. Well, and I feel like that just, totally solidified. If you're admitted to the hospital, please stay there, even if, you are feeling good. The infection's not worth it. And so I guess kind of going off of infections, we also had a question about the membranes resealing.
Good. Nice.
Yeah.
Membranes can reseal with one catch, And that's that when rupture happens, typically because of an amniocentesis. And amniocentesis, guys, there's indications for those. I'm a believer in amnio when they're medically indicated. So I don't want anybody to fear the amnio. But even though it's a very small risk of rupture, it's a little puncture that goes into the amniotic sac. We draw out some fluid, usually looking for a genetic test or signs of infection. So something is already going on to get an amnio. But sometimes those can have a leak. Those are the best to reseal. However, if this is a true rupture of the sac, those will not reseal.
Okay, so there's no option.
No. Now I'll tell you, related to this, people have looked at this, and I'm telling you, Liz, this was as recent as May of 2023. Okay, May of 2023. There's an independent group of investigators called the Cochrane database. Okay, it's a thing. So the Cochrane database reviewed for these babies that have their bag of water ruptured very early. Can't we put fluid back in? Makes sense, right? Now, we put fluid back into the uterus in labor. That's called an amnio infusion to protect against some fetal heart rate decelerations. That's very well known.
Yep.
So taking that concept and applying it to this to try to buy time so the baby has more cushion, more fluid, it seems absolutely logical. However, unfortunately, and again, this was as of just 1 year ago, May of 2023, the data says it just doesn't seem very good. because that's a whole that's a whole other set of issues. These usually rupture because of a little bit of infection. There's some inflammation going on. And so this is trying to put a very small Band-Aid on a really large cut. And it's been tried, and there's some very small success stories. That is not standard of care in the US or abroad.
Well, hopefully with, technology in the next 10 years, I don't know, maybe somehow we can advance to that. Because you're right, it sounds so logical, but we're just not there yet. I know we had a question on Instagram, kind of just going back for a second on the sepsis. How common is sepsis in pregnant women?
Oh boy. So talk about a big loaded question, because one of the main drivers of maternal mortality, you all see the news. I mean, we're all fighting for this, guys.
Absolutely.
We're trying to make this better. Maternal mortality means we're all mortal. It's end of life. Maternal death is really grouped into a couple of boxes: hypertensive issues, stroke, and part of hypertensive issues is cardiac issues. Then comes infection. That's sepsis, which we're going to get into. And then things like thromboembolism, people that throw clots and things like this.
Yes.
Now, those are all pregnancy related. Sadly, Liz, the most common cause of maternal deaths aren't pregnancy related. They're accidents and homicide. I mean, horrifying. And look at,
oh my gosh.
Okay. I mean, and by accidents, I mean, the motor vehicle accident, because life is messy. It's terrifying. So we have non-pregnancy related causes, and that made national news. It's made national news many times. That's why we screen for domestic violence and partner abuse and everything else. Now, so having said that, even though that is a cause of maternal mortality, sepsis from a variety of causes is real, and we're all on the lookout for it. Every hospital that's accredited has a sepsis watch. Prolonged rupture of membranes is a risk factor for sepsis. Prolonged labor, just labor by prolonged labor, is more than 18 hours, is a risk factor for sepsis.
Wow, 18 hours.
So 18 hours is called prolonged rupture. That's another ROM.
Okay.
So ROM is prolonged. Now, that's not an indication for C-section. It's only an indication for antibiotics if you have GBS as a culture. And if you don't have GBS as a test antepartum, then 18 hours is a cutoff to where you give antibiotics to prevent GBS sepsis.
Okay.
But 18 hours is the definition of PROM, prolonged rupture.
Okay. Interesting.
Related to labor, yes. And sepsis, remember this, guys, can come from non-obstetrical issues. So if a patient who's diabetic and has a boil, that boil in pregnancy, because of the changes in the system, that can lead to sepsis.
Yeah. It takes on a whole,
and it takes on a whole new thing. And I had we have a little podcast, and one of the recent episodes that we did is called Group A Strep in Pregnancy. Devastating. Group A strep, which is the bacteria we naturally have in our mouth. That's strep throat.
Yep.
Strep throat. I mean, common as that, right? Kids get strep throat. In pregnancy, that little bacteria, that little invader can cause significant problems.
Wow.
So group A strep sepsis in pregnancy is it's a big watch thing on a national level. We're aware of this. So you got to act fast. Again, signs of high heart rate, fever, sweating, this unnervedness, get checked. And another source of of course, of sepsis is pyelonephritis, kidney infection. For things like, I had a urine infection. I knew it had to pee all night long. It kind of burns, but I don't want to bother anybody. In pregnancy, bother people.
Bother people. Thank you for saying that. I hope everybody hears that, because I know so many of us that have experienced loss. I mean, a lot of it came down to, I didn't want to bother anyone, and so I waited a little bit. And so I think it's just so reassuring for everyone to hear a medical provider say, don't wait, go. Like it's not something that we just try to wait out. So thank you again for reiterating that, because it's huge for this community.
And sepsis, we talked about how frequent it is when, again, top five of maternal morbidity and mortality. There's a mom that I somehow got connected through our Instagram site, who had group A strep, who lost her limbs. Okay. So, and I follow, she gives little kind of progress reports on Insta. Guys, birth should be the happiest time in a couple's life, in a family, right? It's arrival of a new life. It's a new person. she almost, I mean, ventilator, she almost died. She lost limbs because of gangrenous change. It's a reminder that everything is good until it's not.
Yes. Yep. Yep.
And it's devastating. So top five.
Yeah.
Top five. It's on the top five of severe maternal morbidity and mortality. That's why. And some of those cases, up to about 40% based on who you read, are those who mistook, I just thought I had a sore throat. I was okay. You get fever when you get a sore throat. It's okay.
Yeah, I'm sure.
Go get checked.
Yep. Absolutely. Oh my gosh. I feel like I have learned so much. So our last question, and to kind of, I guess, kind of wrap things up a little bit. If you have experienced pre-prom before, will it occur in future pregnancies?
It's amazing. We carry with us our story, not just emotionally,
Yeah.
things that have the good and the bad, but also obstetrically. So yes. So
Yeah.
listen to this, guys. We got so much to talk. We got to do this again because we got so much
Oh
things.
yeah. Oh, you're coming back. I already know.
I mean, there's just so much, and to do. I really want to do this service. We don't have time. I mean, there's so much to talk about. What are latency antibiotics? When you get steroids? What is MAG? How does MAG work? I mean, there's just so much.
Yeah.
But your history, that's why we sit down when you go into your doctor's office, nurse, midwife, whatever. The first thing they do, it's called a history. You do a history and physical, an H&P. Yeah. History matters. The reason we spend 20 minutes, 30 minutes, if it's a brand new intern, sometimes they take an hour.
That's okay.
That's okay. It's all right. It's brand new intern season for us who are in academic. Oh my goodness. It matters. So here's what we know. Yes, if a patient has PPROM, they do have a higher chance of it happening again. However, the good news is it's about 10%. So I look at that. You can look at 10%. That's horrific. I look at that at 90%. It won't.
Yeah.
It's all how you look at it. Okay. Now, so let's do it in numbers in general. PPROM, so rupture of membranes without labor between 20 and 37 weeks happens around 4% of the time. Okay. 4%. Okay. At term, it's double that. It's like 8 to 10%. It happens more likely at term because the body's getting ready. Sometimes things haven't figured out yet. Right.
But you're much safer then.
Yes. So PPROM between 20 and 37 typically is around 4%. If you had it once in the subsequent pregnancy, that risk is now that 8%. So what happens at term now, because you've owned that number now earlier.
Yeah.
You got that, right? So yes, you are at risk. The good news is if you take a look at 8%, 10%, 90% means that you won't. But here's the catch. If you avoid, because the body is funny, the body carries the memory. If a patient had PPROM in one pregnancy and they don't have it in the other, which is fantastic, they may not be out of the woods because data has shown repetitively for the last 3 decades, those patients, if they escape preterm rupture, which is great, can have a higher risk of preterm labor because the uterus somehow is telling you, it's talking to us with that first rupture membrane. Does that make sense? So if it happened to the first, this is a key that you're considered high-risk pregnancy. You would probably need more frequent visits, listen to your body, pay attention. And we thought we had a way to prevent preterm birth. We thought we did for about 15 years, which was IM progesterone. Now we now know that new data shows that probably was not what we thought it was. Okay. You will have to leave progesterone in another side. But there are things that can be done to try to prevent that. No smoking, healthy weight, measuring cervical length. There's ways to try to predict preterm birth with higher accuracy. And that's right out of the American College of OBGYN guidelines.
Wow. Okay. Ooh, that was so helpful. I think we just have this last question up here for the evening. When is the risk of sepsis the highest with stillbirth? How long can we safely wait to deliver?
Oh, okay. So we can't rush that because stillbirth is very heavy. So stillbirth happens, and sometimes the majority of the time we look for answers, and sometimes we don't get one. So with the stillbirth, we always say the baby has some of the answers. So a standard guideline, although parents, the mother and the father, the couple have to decide whether they want to pursue fetal autopsy or not, because sometimes fetal autopsy gives a lot of information. Study the placenta. The placenta has a lot of information. Genetics on the child also has a lot of information. So there's three. Those are the three main buckets. Is it the placenta? Is it something in the mother with an infectious cause? Is it the child, something that we're not seeing? And now we know that some of those unexplained stillbirths are actually kind of baby arrhythmias that have no warning, guys.
Wow.
Do y'all get this? So those are called channels, or those are electrical channel defects in the heart. And it's like somehow the baby went through some kind of weird arrhythmia, and nobody knew, because we're not on the baby's heart monitor 24/7.
Okay. Yeah. And so
number one is that it's terrifying, horrifying, and I don't want anybody who's considering pregnancy to go, what if, because the what ifs will drive you crazy. Enjoy the day, enjoy the pregnancy, because the last thing we want to do on this program or any is fear. No, we want to educate, because there's things that we just can't control. Now, the risk of sepsis with the stillbirth was the question. It's based on when the stillbirth first happened. There is, after every 24 hours, an incremental increase in the rate of sepsis.
Okay.
However, the final decision medically, we would like to have that induced if the patient and the family is emotionally and physically ready within 12 hours. But the patient has to make that decision. I do not recommend, nor do national guidelines, waiting more than 5 to 7 days. That is a true risk.
Yeah.
Now, and it's amazing, because I've been there. I've been in practice 24 years. We respect everybody. We're team patient. So if she says, I know the risk, I want to hang on to this. And guys, the psychology of this, we don't have time to discuss. Yeah. If that's the case, fine. But I'm going to you got to be in contact every 24 hours. You can send us a message on your EMR, take your temperature. And should that temperature start to rise, we want you to be around for the next time. So at some point we have to, we go through it, we hammer it, we got to run through the door so that the door will close behind us, and we can keep going forward.
Yeah, that was helpful. Thank you. And, for us, PUSH is founded by families who experience stillbirth. And this is all what we wish we knew. When I was pregnant, I thought I was educated. I always say that. I read every book. I was so healthy. I did this, I did that. But it's discussions like these that are going to slowly put an end towards preventable stillbirth, with people being more aware of when to take themselves to the doctor, of when or just certain signs to look for. So, Dr. Chapa, I cannot thank you enough for being here. And I already know I will be asking you to come back. But I also just want you to share, before we end, where can people listen to your podcast?
Yeah, great. So it's available. Where most podcasts are, it's clinical, Dr. Chapa's Clinical Pearls. Now, it's meant, of course, to be for the resident physician, the attending, the nurse practitioner, the midwife. It's all evidence-based, based on brand new stuff. We don't try to make it lecture. We meant to make it very interactive, kind of fun, and more conversational. But it's enough. It's medically enough to be medically and technically accurate, yet still friendly enough to be heard by patients. So it is obviously free. It's on Spotify, and that's our mission. I have a full-time job. I actually have several hats that we wear in our role, but this is a personal passion of ours, to having gone through some things ourselves. We lost our first pregnancy was a miscarriage. I feel that patient education isn't just for physicians. It's when the way that you win is when you impact the community. And so we arm ourselves. So they come in and go, I think I may have PROM. Oh my goodness. Are you a nurse, or how do you know that was a term? No, I've read, I know what I'm looking for. Yeah. Let's do it. That's our goal. That's our goal. We are on the same team.
Yeah. Well, thank you so much. I can't wait to see, all the other comments that we have. And for anyone that, if this is your first time tuning in, please make sure you visit the PUSH Pregnancy website. We have amazing tip cards in English and in Spanish for people that, we want you to print it out and put it on your fridge, so that, when you notice little things, you're encouraged to go and ask questions and get checked out. So make sure you look at that. We also have pregnancy after loss resources and bereavement resources as well. And Dr. Chapa, thank you again so much. And I hope that we see you again here soon.
Yeah, you all have a great vision. This is a wonderful platform. So kudos to you for doing it. All right, everyone. Have a great evening.
Bye, everyone.